Like to thank you all for coming to the first in our 2026 series of policy dialogues. This one is focused on patient-reported outcome measures, enabling value-based healthcare. My name's Professor Nicholas Goodwin. I am the Director of Policy here at the Centre for Research in Health System Performance, which has a mission to become an academic centre of excellence and support systems to improve health system performance. Part of our role is to develop policy dialogues and develop policy briefs to understand the nature of important subjects, the evidence behind it, how best they might be implemented, but specifically to bring out some of the key issues that policymakers and senior decision makers really need to know or consider in order to get the greatest impact from these new innovations. For those of you online, we will be recording the webinar, so it'll be available for you to view afterwards on our website. And our speakers have agreed to also share slides as well, which we'll send to you in a PDF document. And you will be notified after the event. As we go through, you might have a lot of questions. And so please type your questions into the question and answer box, not the chat function, but the question and answer box. And we'll see whether we can come back to some of those questions as we go through. If not, we've agreed that we might look at those questions afterwards and maybe consider some responses to you as well. So welcome all. I'd first then like to invite Dr. Albert Tai to provide the opening remarks. He's Director of Value, Safety and Performance Division at the Ministry of Health in Singapore. Dr. Tai, over to you.
Yep. I just want to check whether or not people can see the slides now.
Yeah, slides are perfect.
Okay. Just give me a sec. Okay, let me just start off by saying actually, thank you for Nicholas for inviting me to deliver some messages from the ministry standpoint on how we actually been trying to deliver PROMs as part of our bigger AVBC movement. Just to share with everybody that since last year, the ministry has embarked on this huge movement called appropriate and value-based care, and it's really about how do we move forward from what we have been doing for the past few decades. In fact, value-based care is something that we've been doing for quite a while, since 2015, and we have been moving from strength to strength across the years. But it's really only in recent years that we really have been trying to amplify the message of value-based care, especially at this point in time where we are also conscious about how do we sustain our healthcare system financially and yet still deliver outcomes that benefit patients. So actually, AVBC is something that we started last year. In fact, we had made a concerted effort to bring this message across the board because we thought that this was the right time with the momentum we have gained through the years to launch a movement that would foster a value-conscious culture among policymakers, healthcare providers, and practitioners to improve patient outcomes. And at its heart, it's really about delivering evidence-based practices while avoiding over, under, and misuse of healthcare interventions. And a very, very big pillar of what we hope to achieve with AVBC is patient-centeredness as well. The 5 core principles as articulated in a primer that we just issued also last year, just to set the common language for which all of us can talk about appropriate and value-based care is based on 5 principles. And I think there's nothing new about these 5 principles, but I would focus more on, apart from the fact that it should be evidence-based, it should be cost-effective, there is also that principle that patient is centered, care is patient-centered. And this is where actually PROMs really come to the picture. One of the things that we consciously have thought of as an intensified push towards AVBC is in realizing 6 key changes at every organization, including the ministry. So this applies to the entire healthcare ecosystem, in fact. And when we talk about what these 6 key changes are, it's we actually have put this together as Focus C. And one of them actually is about outcome measurements. The O here is talking about outcome measurements. And we're not just talking about the usual metrics of success, of clinical success, which is what we're more accustomed to, healthcare utilization rates, complication rates, safety issues, all these things. These are what the ministry has been tracking for all this time, but actually For those who have been working with the ministry in the past few years, we have been consciously putting effort into also then what are the patient-centered outcomes that we do want to start collecting. And I think this is something that is universal across a lot of healthcare systems, not just unique to Singapore. A lot of countries are also starting to optimize, take advantage of what patient-reported outcomes brings to the table in terms of clinical decision making. And that's why that's one of the six key changes that we have been advocating to our cluster partners, not just in the public, but also in the private sector. And just to uh, uh, close off, what I meant by that is that when we start talking about O in particular, as you can see here, we try to articulate what are the components of the different key changes. When we talk about outcome measurements, we are now acknowledging the importance of patient-reported outcomes and integrating this data into daily decision making. Because we do acknowledge that integrating data into care delivery enhances patient experiences as well as drives continuous improvement and accountability. And so you'll see increasingly as some of our partners like Shika, who have been working directly with us, we have created a national PROM strategy. We have tried to figure out what would be components of this strategy. How do we make this more available to clinicians and to patients, and how do we make clinicians make the most out of this data that's available? There are a lot of challenges. I'm sure you'll hear from the rest of the panel, but this is work in progress. But this is really just to set the stage that the ministry is very much focused also, not just is now focused on how to make value-based care work, specifically AVBC. And PROMS is a big component of how we want to make this happen. So again, thank you for your for allowing us this chance to share what the ministry's view is on PROMs and how we actually can. I'm looking forward to hear how the different parties involved here can actually help us advance this PROMs work. Thank you very much, Nick.
Thank you, Dr. Tai. And we're very well ahead of schedule. So that was a very clear articulation of what is kind of an ambitious change of culture, isn't it, in the way that we think about things. And I think the what you've presented is very clear as a strategy. Um, so I'm going to ask, I've got a couple of minutes. I'm going to ask you one question, and maybe this is a question I might ask to everybody as we go through. But if you were to pick up on one or two of the key issues or challenges that you think the system is going to face to help you move in the direction of your
Yeah.
strategy to its ultimate outcome, where would you place your
Oh,
one or two or three?
yeah, thanks for asking that question because that was what we were grappling with, and that's what the strategy was supposed to address. There are actually three key issues that we wanted to address, and that's part of the strategy. Actually, the first one actually is how do we, as you know, different hospitals will, there are a lot of tools. That's the first thing. There's a lot of tools. Even one condition will have many tools, many PROMS tools. Of course, you have EQ5D, which is universal. But when you start talking about what would be PROMS for, let's say, TKR, for CHF, for diabetes, for, let's say, arthritis, even for cataract surgery, they have different tools that's available. So I think the first order of things for us in the ministry was like to get the clusters to come together and say, let's identify where PROMS tools are the most widely used, and let's come up with a harmonized set so that we actually can start comparing how PROMs looks like from at the national level. So that's the first order of things. Second order of things actually is that a lot of the PROMs tools are also, while they are internationally established, we do want to contextualize that to the local setting, especially with with our different ethnic groups that actually is, you want to translate this into something that is applicable to, let's say, our Malay Singaporeans, to the Indian. So contextualizing to not just the language, but also to the local context, because we realize that some of the PROMS tools are not really relevant. Some of the questions in the PROMS tools are not relevant to Singapore context. So that's the other thing that we've been trying to do as well as part of the strategy. The third actually is that how do we actually deploy the PROMS tool? I think this is a universal problem again. Different institutions have done this through their own apps, for instance. But also this has limited reach as well. And we are looking at like how do we leverage on all our national tools. Like for instance, we're looking at Health Hub. which is already a national tool, that cuts across the different clusters, and most of the population would have downloaded Hub. So how do we incorporate, for instance, what IT platform or infrastructure should we put the PROMs tools that will allow patients to access this, not just when they're inpatient, when you do the initial PROMs, but also when they're already outpatient? Because that's usually the challenge. When you try to collect data 3 months later, 6 months later, 12 months later, 18 months later, that's where actually the drop-offs happen. It's easier to collect prompts when they are, captured audience in the hospital, but when they're outside, that's where it's difficult. So I think we were trying to figure out what would be the best way to reach out to patients when they're already out of the hospital and they're outpatient. And these are I'd say the three things that we are trying to address in terms of the national strategy,
Yeah.
together with our clusters. Yeah.
Thank you. The three foundational problems, and I know my colleagues coming in later will speak to the third challenge in particular because they've got some thoughts on that from coming from patient representative organizations. So we'll listen to them later. Thank you so much, Dr. Tai. We do have one question, and we are in time. And it says, if we modify and contextualize the PROM questions which are validated, does it affect the accuracy, reliability of data collection? How can we mitigate this?
That's right. Yes, yes. So when we do contextualize, we do have to validate. So that's actually where we already reach out to quite a number of our academics, from Soci Hawk, from even Shema, to help us. If we do contextualize, we need to validate. So yes, that's part of the work. When you
Yeah.
contextualize, you do have to validate that. Yeah.
Thank you so much. And that was a question from Jermaine. Thank you for that question. And I hope you can add in more questions as we go. With that, thank you so much. We're now going to pass to our second speaker, who's going to provide our first key presentation. That's Professor Jose Valderas. He has many roles, but chief amongst them here is he's director of the Center for Research in Health System Performance. And he's going to provide his presentation on enabling value-based care, why PROMs matter. So, Chema, you
Thank
have
you
the
very
floor.
much, Nick, for the presentation. I'm really excited about this policy dialogue. It's, as you know, a topic very close to my heart and to my experience, and I'm delighted to share this brief overview of how PROMs matter for enabling value-based care. So. Basically, I will talk just in this brief introduction about four main things. So, what are PROMs? So, what are we talking about? Why we would like to use them? Why people think it's a good idea? Whether it really matters actually if we do. Is this a luxury that we have, or is it something that we cannot help but using given the particular value? And also, I mean, what are the main experiences that we can learn from in terms of how PROMs have been implemented internationally? So this is very brief, low level, but just that we are all on the same page. So PROMs basically are based on eliciting stimuli. I mean, putting forward stimuli to people. So let's say in the form of a question: how much bodily pain did you have during the past 2 weeks? And then you elicit a response from that individual, which may be on a scale. I mean, Likert scale they called the ones that have a discrete, a set range of options, or they can be on a visual analog scale. So you have the stimulus, you have the response, and then you have some form of algorithm, some form of magic recipe that transforms all those answers into a scoring, and that score can be overall or can be dimension specific. So some instruments are focused on broad range of things and are satisfied just to give you an overall perspective. Others are able to give you more granularity. That would be domain specific scores. And they sometimes use weights, sometimes they don't. And the weights come from the preferences of patients, or may come from the preferences of the end users, sometimes when they are clinicians or the stakeholders. That's in a nutshell what a PROM is. What does it measure? So this is an attempt in which we try to combine together the Wilson and Curie model that was based in the late 90s JAMA paper, and also the International Classification of Functioning by the WHO. And I will only highlight these four boxes that are symptom status, basically what people, how the bodily experiences of health, functional status, what people can and cannot do in real life settings, general perceptions, the integration of how people of symptoms and functional status for people to see, okay, I mean, if I'm asking in relation to my health, am I good? Am I bad? I mean, in comparison to others. And finally, health-related quality of life tries to capture a higher order construct, a higher sophistication in terms, okay, given my health, how does it contribute to my generic well-being? This is what you have here, for instance, is an example of such a PROM. You have the stimuli, I mean, that's the WHO 5 well-being index. It measures overall well-being. You have 5 questions. The first one reads, I felt cheerful and good spirits. And people have to respond whether they have felt cheerful and in good spirits all of the time, most of the time, more than half the time, etc., until no time. And so you elicit a score per item, each of question, if question is called an item, and then doing what I mentioned before, the scoring algorithm, in this case, basically averaging. Responses, you get a total score. This is how people still probably think in relation to prompts, but this is very much a legacy issue. Now we are moving into a completely new era in which we capture the information through computerized adaptive testings, in which we ask the question, given the profile of an individual, we anticipate the most likely response, we select from all possible items the one that may be most useful for measuring for that person, and then based on the subsequent responses, we keep presenting them with different items. And now at CRiHSP, we'll even go in further, and we're trying to use large language models to support with the administration, but eventually also to see whether we can use open-ended text to gather this information. But that's a future development. That's probably how people think in terms of prompts still right now. Okay, so now that we know what prompts are and measure, I mean, we are very busy. If you talk to a clinician, they will tell you that they don't have time for anything else than just seeing patients and examining them and getting tests done and interpreting those tests and providing recommendations, etc., organizing care plans. So can we afford it? Don't we have other more important things to do? Well, prompts capture essential information that cannot be collected with alternative ways. The patient perspectives typically have a correlation of 0.3 with other more objective measurements. And certainly, I mean, there's a common construct being measured, but there are also plenty of stuff that are not covered by those measures. So first of all, is essential information can you capture it differently. Also, prompts can support patient decision and shared making. So by asking people, this is all based on evidence. The prompts, when we ask people questions, they are more engaged in their care because they recognize it's about themselves. And also their own responses can help clarify patient priorities, both for them, but also for the clinicians. When we use them when used for larger groups rather than individual, they can help identify gaps in care, monitor outcomes of specific populations, benchmark providers and performance over time, and inform value-based healthcare and policy. At hospital, regional, and national level, they can allow benchmarking. So we can potentially be used for saying, okay, are patients operated at this hospital? Do they tend to end up being with getting better outcomes? And as I was saying before, there are some of these outcomes that you cannot measure differently. And they can help us reveal difference in outcomes between groups and settings. So it may become very important for equity. and to reduce unwarranted variation. And if you need any additional convincing, I mean, economists who are basically interested in the use of resources routinely use them in economic evaluation so that they can calculate quality adjusted life years. And they are at the core of any evaluation in which we decide, the Ministry of Health decides, or the Health Technology Assessment Agency decides whether to recommend or not a treatment. They are embedded there. So I think that we may have very important things to do, but PROMs is certainly one that we should keep doing and start doing more. There is also another rationale. I'll be brief with this, but basically the disease models over time have informed care models. So when we had an infectious disease model, one of the first ones, basically we had one condition, one agent, one treatment, and similarly that replicated a model in which it was a disease specialist and a very linear response. When we started to deal with chronic conditions after the epidemiological transition, we recognized that there was one condition, but then multiple agents and multiple treatments for each of these chronic conditions. And so we were tangled no more in a linear model, but rather in a cycle model with multidisciplinary teams taking care of diagnosis, treatment, monitoring, and a feedback loop that was increasingly relevant. Now, if we consider the multiplicity of conditions that occur in an individual, multiple conditions, multiple agents, multiple treatments, that makes things very significantly more complex. So we have multiple teams trying to coordinate themselves, and then it becomes immediately clear that you need trade-offs. You will not be able to improve everything for any condition for every group. So trades are important. In order to be able to make those trade-offs, you need to understand what are the goals. And this is where PROMs can play a very significant role. And also you have these networks, and you need to be able to communicate this information. So previously, between a single patient and a clinician, you may not need necessarily to distill it into metrics that will convey meaning. Now this is unavoidable. So along this progression, what you can see is that we are more and more interested in whole patient care. So coordination is key, but also person-centeredness is not longer a luxury, but actually one of the guiding principles that allow us to make these decisions. So PROMs, I mean, the easiest way of thinking of them is to use them in clinical decision making. So for instance, they are already being used in the screening for depression, for instance, with the PHQ-9, or they are used, for instance, in appraising the outcome, I mean, and monitoring adverse events in cancer care. So that's what we call supporting clinical decision making. But we can also use them when we aggregate them and we're no longer interested in a single patient, but in a group of patients. They can be elevated to be used for quality assessment. As I mentioned before, we can start to think, okay, is this team working? I mean, given the characteristics, the case mix that they have, is this actually being on par with expectations? Or can we actually learn from this hospital because they seem to be getting very good outcomes? What are they doing that others may be missing? And at even another level, when you elevate it over the specific providers, PROMs help you understand the population needs. So they help characterize. I was just literally off, and I will be back a workshop with the global burden of disease in Southeast Asia, Asian countries. And the metrics that have to do with incidence and prevalence of diseases are certainly relevant, but they are not patient-centric in the sense that these are not people talking about what health means to them. So this is another way in which we can characterize population needs and understand whether health systems actually meet those needs. Do we have evidence for whether PROMs actually work? I mean, these are all very good ideas. I may or may have not succeeded in making the case for them. But what does the hard evidence do? Well, we conducted Cochrane review well over 100 randomized control trials in which people, a group of peoples were randomized to actually receiving information of PROMs, that would be the clinicians and or their patients, or not receiving that information. And very interestingly, what was observed is that the quality of life of those people were improved. So, and that was the only intervention that was there. So there was no other ingredient. I mean, when comparing all the effects across groups. So just by providing information about PROMs in the clinical encounters or for clinical purposes, the evidence supports improved in quality of life of people. Something that was also interesting that we found was a bit of a gap between diagnosis and treatment. We expected a cascade of effects. So when you use this information for understanding the problems of the people, making diagnosis, for instance, this you expect a bigger effect. And when people have to make treatments decisions about treatment, okay, probably a smaller effect, and more so in terms of what is the impact on the actual disease control and eventually on people's quality of life. And we sort of saw that, but we saw this gap. And we think that that's part because of the reason is that the clinical practice guidelines typically make very little effort in distilling the evidence on how treatments improve quality of life. And we believe that part of the effect on quality of life that I have mentioned before is actually due to the fact that patients also receive the information and they received cues, both in terms of how they could make it better, but also understood, were confirmed that health was about them, not about some people in white coats making decisions. We further wanted to understand how things actually worked when implemented in real life. And we did a real synthesis with that was some work that I really enjoyed with our colleagues in Leeds, and also on the School of Tropical Medicine and Hygiene, the Nick Black's team. And I think that one of the most important things is that clarity and training are important. And so significant investments are needed to support investment of resources and time in helping clinicians make sense of the information. Also, something that is relevant, this was an effort to trying to characterize the two main pathways that we believe are important. In red, you have the more, if you want, medical-oriented one. We think in terms of clinical management. How am I for time? 5 more minutes?
You have 2 minutes.
2 minutes, okay. Through clinical management, your effort is more aligned with standardized measurement. When you come from a psychosocial model, it's the patient-centeredness that is important. And so you may be more interested in other PROMs that have received less interest, which are individualized PROMs. We don't have time for that, but watch this space for this sort of PROMs. So how has this been used? My fourth item. So one of the main drivers has been ICHOM. And ICHOM has done a very good job at the International Consortium for Health Outcomes Measurement, a collaboration between Harvard Business School, Karolinska, and the Boston Consulting Group. And they basically have made efforts which are condition specific. We brought to their attention that there was some problems with this approach, and so we were invited to develop a overall adult health core set. And so PROMs are now part of this set of outcomes that ICHOM are promoting to establish, if you want, a common framework to be used across the whole pathway of care for many conditions, but now also for specific groups of patients. And PROMs are a core part of this. The OECD was particularly interested following the experience of the NHS. The NHS, the National Health System in the UK, was at the forefront by embracing PROMs for 4 elective conditions. Basically, they measured before and after the surgery the PROMs for a hip and knee replacement, and 2 more that they eventually dropped. And the OECD was very interested in this initiative. And so they scaled it up to include now close to 20 countries. And this is big. I will just bring your to attention what OECD has been measuring in these 20 countries. Health behaviors, okay, health capabilities, which is how people are supporting in taking care of and contributing to their healthcare. Patient-reported experiences, and also patient-reported outcomes as the core, not the ultimate goal of the health system. And members of CRiHSP we have been very fortunate to contribute to the development of the framework, the instrumentation, and to the evaluation. And you can have more information in the reports that is available online. And what you can see here to your right is the ranking of the countries in terms of 10 indicators, all of which are patient reported, and half of them are patient reported outcome measures. So we know that PROMs are self-reports of people's health, covering different aspects. We've seen symptoms, functioning, self-reported health, quality of life. We know that they provide distinct information, that they operationalize in particular patient-centeredness, that there is accumulating evidence of the benefits at clinical level, and increasingly, but at a slower pace, in terms of the other levels that I mentioned, benchmarking, provider quality, and also population needs. And that there are a significant and increasing number of international experiences in which PROMs have been successfully implemented at different levels. Thank you very much for your attention. Over to you, Nick.
Thank you, Professor Valderas. That was such an expert overview of what PROMs can do, and I think you've made the case for change very strongly. Really interesting how relatively simple tools can come up with quite sophisticated data sets that enable you to do many things, from quality improvement and clinical decision making through to tackling variations, economic analysis, improving quality of life, engaging with patients, so many different ways in which you potentially can use PROMs. And some of the questions that we've had, which we might come to at the end, ask about how do we use the PROMs. But I'm going to ask now our next speaker, Dr. Brenda Reese-Brennan, Mental Health Integration Director from Intermountain Healthcare in the USA, to pick up a presentation on achieving value through integrated mental health care and using health outcomes data to improve system performance. And in a way, this is a real world example that feeds back to what Dr. Albert Tai was talking about around how do you integrate data into clinical decision making to improve quality and build relationships. And that's something I know your team and you personally, Brenda, have been doing very successfully for a number of years. So very glad to have you with us. I know it's late there where you are, but I'm passing over to you.
Can you hear me okay? I'm just trying to pull up my slides here. Are they coming up?
And for those online, please keep sending, they're not on the slides yet, keep sending your questions, because if we can't get to them during the webinar, we will seek to answer them afterwards so that you get a documented list of responses.
Your patience, and thank you for the opportunity for me to share with you achieving value through integrated mental health care. This is going to be a naturalistic story of holding the complex whole. And when I'm talking about complex, I'm talking about context as well. By capturing and normalizing mental health as routine health in the design, implementation, and evaluation of valued lived experiences. Mental health integration has had a 25-year history from the first Surgeon General's meeting in the United States in 2000 through today, in investing in a culture of relational reciprocity to achieve whole health. But the story of holding the complex whole is about building a culture of collaboration and mutual gains and shared responsibility. This leads to trusted health outcomes and economic efficiencies. Mutual gains and responsibilities that establish three essential valued norms. The first, trusting relationships. These are the most healing, underleveraged, deficient human resources in healthcare today. Relational reciprocity. It was the way we relate and connect to each other, and everyone contributes to a shared purpose. And complexity, not being a math problem, but an asset that determines the quality and the equity of outcomes. These are the three conditions. So now let's talk about primary care. Doing good is good business in primary care. Primary care is the home base of trust and a place where families often have their first conversation about their emotional and physical health with a trusted primary care provider. So our story began in 1998 when reputable primary care physicians had sold their practice and joined Intermountain's medical group that was actually expanding their hospital care to ambulatory care. And they raised their voices to challenge Intermountain's business strategy on how to improve quality for diabetes and asthma. They were all about improving quality care and meeting the benchmarks that Intermountain was known nationally for. But they basically said chasing separate diseases in primary care is non-negotiable. This is not the whole burden of what our families are struggling with. What are you going to do to help us with the domestic violence, the depression, the anxiety that they come in with their diabetes visit? We can't get to the diabetes. The CEO of the medical group of Intermountain did something unexpected. She listened. She took them seriously. She valued their experience and realized the most important thing she could do was building trust for her doctors. She needed to help them improve the quality. What did they need from her? They needed access to mental health integration. So in a brave act of reciprocity, she activated and commissioned resources. We're going to make mental health routine medical care, routine mental health, same appointment, same trusting relations. We created an interprofessional team-based care design and high-functioning teams that are used as well in implementing high primary care in the National Academy of Sciences report. And you can see the picture over here of the family and the patient in the center. Everyone has a say. This optimizes the patient and family at the center of the design. Intermountain intentionally designed for integration of mental and physical health, not a separate program down the hall. It successfully invented in teams functioning as whole teams, and to treat people as whole and feeling truly cared for. This required building an iterative, standardized process of rules and norms that provided the learning conditions for clinics and teams to progress through implementation phases of planning, adoption, and becoming routinized towards the goal of shared purpose of wellness and whole health. So why were there 5 conditions? There were 5 conditions because every time we did one of these and got them wrong, we had to do them over. They became key essential elements of reciprocity, leadership and culture, and accountable, cooperative, reciprocal relationships. Basically, mental health is everyone's business. The clinical workflow, engaging patients and families on the team and matching their level, their story of their complexity and context and the needs to the right level of support and training. Information systems had to be integrated. Electronic medical records, registries, virtual technology to support communication of the teams, performance, benchmarking, and financing and operations, projecting the budget, measuring and matching stratification, and monitoring adoption maturity towards high-functioning routinized teams. And the 5th was community resources. A primary care clinic cannot deal with the context of everything that's coming in all by themselves. Who are the community partners to help us engage the population and scale sustainable wellness throughout our communities? This is an example of the data infrastructure that supported the cultural transformation of team-based care. This was not only patient-reported measures, it was operational reported measures, claims reported measures, and team-reported measures, actually measuring their score, MHI scorecard, and operations towards team-based care, all to produce a practice suite and dashboard and actionable data that would support relational decision-making and care improvements. which began with the clinical process, the patient and the family telling us, how complex is your life, both emotionally and physically right now, and what are the things that you need to support you moving forward. This helped us to design routine care, mild complexity, moderate complexity, high complexity, and then transition to specialty care. So the data that was inputted by the patient's report goes into the medical record, gets stored then in a depression registry of over 800,000 patients that we've been tracking longitudinally since 2000. And then these are all used and integrated together to build a whole picture of team feedback. How is your team doing? How are your patients doing? Where are the gaps? Where do we need to move forward? Also, with the measurement of the actionable data is the teams measuring their performance towards team routinization. We have a mental health integration scorecard that's done at a yearly basis, and this tells us what is the level of team culture and the organizational support that helps produce the outcomes. Teams and clinics go through a planning phase of planning and designing their workflow, reviewing and tracking operational outcomes, and then moving into adoption, where basically if they think that Intermountain's ruined their life because they have too much to do, they can't possibly do one more thing or add one more thing. And then to the point where they get to be routinized, where it becomes routine, and doctors will not run their clinics without their lab and their MHI because it has reduced the burden so greatly for their patients and for them. So what do patients think? What do patients tell us about this culture of team interactions and coordinated team-based care? Well, this was a very enlightening piece of outcome that came from our ethnographic studies, where we interviewed patients that were receiving care in our clinics and providers that were providing them. And when you look at dividing them according to the clinics that were organized for potential adoption and routinized, the staff in the potential clinics already thought they were doing team-based care, but patients were not reporting it. In the adoption phase, the clinics and the patients started reporting a little bit more of team action happening, but not until the routinized phase were patients actually experiencing the team interactions and being cared for by a team, as well as the staff following the team process and reporting that my doctor was the first person to treat me as a whole person. I'm connected to a team that talks to each other, and I get better results when we're on the same page. This outcome alone helped us transform many of the perceptions of how we are measuring outcomes and getting better results when we're all on the same page, including the patient and the family. This allowed us to do a retrospective study over 10 years where we tracked patients that were seen in the primary care clinics and then were exposed to team-based care or traditional practice management. And we found value that was delivering results that exceeded the expectations of Intermountain of developing this program and scaling it over time. The study showed that integrating mental and physical health through primary care teams actually had better clinical outcomes and lower costs. Over 113,000 participants and 113 primary care providers. And if you were a patient that was being exposed to the team-based care relational process in the 27 clinics of team-based care, you were being screened for depression and activated on your depression care process. You had a documented care plan, a self-care plan for your depression, your asthma, your diabetes, and you were adherent to your diabetes protocols. You were also not in the emergency room. You are not having hospital admissions, and your primary care encounters actually went down because you had a team and care management that was reaching out to you. The team-based care at Intermountain cost Intermountain $22.19 per patient per year, and we saved Intermountain $115 per patient per year. This study was expanded and scaled due to the results in JAMA, but this slide here shows you building a community of continuous relationships over time with transparent and meaningful outcomes. You can see through the course of the years how the clinics transformed to becoming, in the green bars, more and more routinized clinics over time. And this was driven by leadership, by data, and by people being able to work together and actually report these outcomes. and trustworthy management and team performance. This is an important slide that helps you really realize how much you can do and how long it takes to have teams and make even further acceleration of adoption and routinization over time. But relationships have an efficiency cost, as we know from North's work on transactional costs. Every transaction has two components, one economic, terms of the deal, the payment, the financing, and one relational, the shared values, the collective action, the trust. In our current healthcare environment, there's intense financial pressure to trade away from the relational to satisfy economic efficiency. And the real cost of team-based care in 2016, when it was published in JAMA, actually did not go back to the clinics that made the changes. It went to the whole system and saved money for the whole system, but there was no economic formula in the United States to pay for relational team-based care. 10 years later, we have modernization and improving pay for primary care and medicine due to our primary care report that was published in 2021. And for the first time in the history of the United States, the CMS payment schedule is changing towards a relational financing of relational team-based care activity to support quality in primary care. This is trust-producing efficiency, and this will help us shape the norms and the rules that govern collective action for efficient economic resource allocation, and let me say again, trustworthy management. So what is the value of preserving trust? Actually, Elinor Ahlstrom's science helps us really see that individuals collectively achieve better predictive outcomes when institutions' environments provide for reciprocation, gain from trusting relationships rather than those on purely selfish motives. There's no way to achieve these trusting relationships without really hearing the story from patients and staff and people that we want to produce these outcomes. So MHI at Intermountain was actually a small autonomous unit of governance with a viable intentional collaboration and management to really solve the specific concerns that they were designed to protect and improve: mental health, physical health, whole health. Elinor Ahlstrom also gives us guidance of collective action principles that can help us create the conditions for trust. At MHI and the MHI that we did at Intermountain, we had clear boundaries and roles and local authority. Clinics were able to adopt the standardized processes and match them to what locally was needed by their patients, by their staff, and by their community. We had wide participation and collective choice. These were self-organizing clinics, and there was fairness in the resource use. Mental health resources are still short. Paying for mental health in our country is still inadequate. Paying for primary care in our country is still inadequate. But with the implementation environment and the monitoring of rewards and sanctions, we were able to actually show that by collective action, we could actually improve the environment and the culture around providing whole person care. We also had open communication to resolve disputes and the ongoing iterative changes that needed to happen through implementation process. This was actually valuing the lived experience of not just patients that were attending primary care to receive whole health, but also the people of the burden, the primary care staff and folks that were trying to actually work harder, be smarter, but also provide good business and being able to move that forward. So why does that matter? And we talked about a little bit earlier, the earlier speaker, about why do PROMs matter most? Understanding what others truly need is really the first step in creating meaningful value. And these were actually items that were presented through our ethnographic studies of what patients told us what really matters most to them. And did we care? Are they being heard? Do they want to trust us? They want to know if we're competent and know what we're doing. And a really strong highlight was staying well. They want to stay well. Patients would report, my depression no longer defines who I am. What defines who I am is when I can work, when I can spend time with my family, and when I can be active, and that we matter. We are just not individual patients coming in and out of the clinics. We have families, we have communities, we matter together. The whole matters. And what they value meant to them and what is value for them was getting to the root of the problem, making it affordable and successful. So the outcomes now that we are looking at and actually learning from looking back at the mental health integration experience at Intermountain is, what are the outcomes that actually need to be measured, and how do we define them? It's more than just a PHQ-9. It's more than just a diabetes hemoglobin getting better. And many of the outcomes that we collect are for other people other than the people that they were meant to be for. So one of the things that we are pushing for and working towards is really considering, how would we design a measurement system that actually makes the relationship the outcome? And that's exciting work ahead, because relationships matter. Thank you very much, and I look forward to your questions.
Thank you so much. And you see the round of applause coming there on the screen. It's always a fantastically inspiring example, Brenda, of what you've been able to achieve and the timescale of that as well. We are a couple of minutes behind, but I did want to ask one question that's come up. It's come up in two or three of the comments, and it regards the ability, particularly of the clinicians, to engage, because you're asking them to do additional activity by interpreting the data or supporting PROMs in practice, and somehow there's often a barrier to get clinicians engaged in using the PROMs. Is that a cultural relational thing? Is it something they need to see the benefit from? But from your experience in engaging with clinicians at Intermountain, what made the difference for them to come to the table and say, I'm really going to use this now? And how long did that take?
They helped design the measures. So they designed the measures for themselves. What was a positive outcome for them? What did they see as positive outcomes for their patients? And their patients did the same. The patients actually gave input on what would be positive. Why should I do this? Make my doctor needs to be happy. So it is relational. It was very relational, and very inclusive. And they were able to decide locally what measures they could add and what measures they couldn't add. But we moved it from measures to value. So we stopped talking about patient satisfaction and physician I mean, no one's satisfied in healthcare. And so we moved it to the lived experience and the meaning, and what creates meaning. And when we heard that primary care doctors, that the mental health integration process and culture was one of the most meaningful things that they improved in their practices, is because they helped their patients, and their patients gave them positive feedback back. And so that was like the really moving forward. They got incentivized with quality, but it was more the meaning of it that really incentivized them to keep going. And then as we scaled and the burden went down, and you have reputation and people talking about my life, I have more time because I have a team, I have support around me, I have protocols, I have measures, I have IT. Then cardiology wanted team-based care, and then OBGYN everybody wants team-based care. But it wasn't just mental health, it was the whole person. We put the whole back together so that we weren't chasing separate diseases and separate outcomes, or regulatory outcomes. And it actually resulted in a policy change that's happening in the United States. So I never thought that would happen.
Yeah. Amazing. We must move on for time, but thank you so much. And I think actually a lot of what you said will resonate with our next speakers. I'd like to invite now our panel responses. So firstly, Nidhi Swarup, who's founding chair of the Alliance of Patients Organizations in Singapore. So Nidhi, to you, and I believe you have a few slides as well.
Thank you so much, Nick. And thanks to the organizing team for inviting me to share a few thoughts on this topic. I must firstly thank all the speakers who came before me, because each one had so many words of wisdom. It resonated at various levels, and hopefully in the panel discussion, we'll have some time to touch on them. Let me go through a few slides just to share what is so important for a patient. Okay, so this is a patient journey map, which might not be seen so easily by people, and it wouldn't be as smooth as I have drawn it here. It's more like the background. It's pretty rough, actually. The journey of a patient is pretty rough, and it goes in multiple circles. We start off with a small symptom, and we end up in a GP's clinic looking for answers. And it could be a one-off thing, which could be like an infectious illness, but that is a simple problem. What's happening more and more on the ground is people are sent to specialists, hopefully quickly, but in many cases, like mine, I was sent to a specialist, and the journey started in 2009 with just feeling fatigued, exhausted, despite sleeping 8 to 10 hours. It started very simply like that. And with a little bit of dizziness, and I attributed it to a holiday that I had gone for with my family. But what happens in many cases is we go through a lot of tests, scans, waiting for reports, a lot of mental stress in that waiting period. And then if the illness escalates, we do get hospitalized. And there's another set of tests and scans that might happen, adding to more stress to the family members in addition to the patient themselves. We do get discharged after, let's say, a week, maybe 2 weeks, and in some cases after a few months. But what also happens after that is we do get diagnosed with comorbidities. And what do I mean by that? In my case, I went through the step 1, 2, 3, 4 times because I got diagnosed with 5 different conditions. And I had 5 specialists taking care of me. So I've gone through various hospitals, various clusters, various specialists, not only here, but also in other countries, to try to figure out what is going on. And that's why I set up, firstly, the Crohn's and Colitis Society of Singapore, which is now 14 years old. And then, having gone through all my experiences of then, if we move to level 6, the number 6 are treatment options. There are some treatment options available, but doctors are a little hesitant to share with patients. And I bring up this point now that before the internet era, it made a lot of sense that patients didn't have access to any information. But ever since Dr. Google arrived, people are always looking for answers. And now we have AI also churning out all kinds of even diagnosis and treatment options for us. So then doctors need to have a little bit of a mind shift where it's okay to share with us our treatment options and we can make a decision as what is best for us. Okay? And of course, then the journey goes on where we need to go for follow-up tests and we have no clue what the doctor is writing after sharing all the things that we go through, what goes into the doctor's notes. We have no access to it. We then move on to palliative care and end-of-life issues, which again, we have no time to express our concerns with the doctor, a specialist, or the entire team. And this is where I see how PROMs could probably play a role. And this slide talks about PROMs in Singapore in the public sector setting. And this I can say because 2 years ago, I actually gathered a few more people to set up the Alliance of Patients Organizations, Singapore. And why did I do that? The interesting journey is, even though I got diagnosed with 5 conditions, and I was seeing so many doctors, there was no coordinator. And how I wished there was one person who could keep track of my entire challenges and care path and my summary of notes. And if there's an infection that lands up in my body, who do I go and see? there were lots of questions and stress was always going up. But fortunately, I'm trained in management as well as counseling. So I could manage myself as well as my family. But my heart really goes out to a lot of people out there who would be in the same boat and would not have all the resources I have access to. And that is why I set up APOS. This alliance now has 13 organizations as members. And what I'm sharing is a collective voice so that everyone can consider these points, not just coming from me as my lived experience, but as a whole group of patients. So on the left of the screen, you can look at the current status, how we view it, okay? And how we see it as is hospitals across the 3 clusters are using generic PROMs to improve processes as well as quality of care, which is absolutely fine. There are very few departments using disease-specific PROMs. So I could easily say I've never come across outcomes being discussed with my specialists. In fact, one of our members also shared that a doctor made a comment, what is the point of PROMs? Which is quite alarming for us as patients, that maybe APOS should work with the hospitals and create awareness how important it is to have outcomes discussed with the patient and the caregivers. Because I bring in the component of caregivers also, because a patient might be a child incapable of sharing. The patient could be a senior incapable of sharing again because of various limitations. The patient could be a middle-aged person like myself, but could be severely ill because of multiple issues. So caregivers' role is important, even in the context of Singapore, because our culture is such. We go to the family to make decisions. We are not individualistic. So it's not just the patient who makes the decision. We need to look at the family dynamic. Who else is the decision maker or a caregiver? That person needs to be part of such dialogues, okay? Which is not happening right now, okay? I move on to the part where patients don't have access to PROMs and their health trends over the years. So if there's no transparency, we are clueless, and then we don't see the importance of it. Most patients don't know anything about PROMs. You might, think that PROMs, the abbreviation, might not be familiar, but even if you say patient-reported outcome measures, the full form, people will not get it. So we need to create awareness. What are PROMs? How do we use them? What is the importance? All these things need to be discussed on the ground. Excuse me, I have a little sore throat. Just one moment.
Okay, maybe one more minute, Nidhi, and then.
Yes, I'm almost done. On the right side of my slide, you can look at future possibilities where we all are familiar with the term value-based healthcare. We are hearing it more and more from the ministry. On the ground, we have patient leaders who can help co-create PROMs. We can provide options to patients. It could be a digital platform or paper-based, based on the patient's preference. Language options have to be provided. The second point is shared decision-making. I touched on it a little bit earlier, but I see PROMs as a common tool that can be used by patients, caregivers, and healthcare teams, okay? And number 3 is a dynamic patient journey, because illness is treated in a dynamic way. The body changes, illness and its severity changes. For example, although I shared I was being cared for by 5 specialists, last 5 years I have actually recovered and I'm on 0 medication. So from 10 tablets per day to 0 is something nobody thought of, but that is where I talk about planning towards recovery. This is what patients want, and can we all work together to co-create such solutions? And I think this is the beginning of a very good conversation. Let's stay connected. Please take a screenshot if you want, and we can continue our conversations. Thank you so much.
Thank you, Nidhi. That was amazing for sharing both your personal story as part of that, but also your insights into how we can better integrate PROMs into making better. It goes back to the relationship angle that Brenda was talking about and really making sense of all of this to improve people's journey. Thank you. I'd now like to ask Ailing Devadas, who's Deputy Director for the Office for Patient Engagement at Lee Kong Chan School of Medicine, to also offer your insights from the patient perspective on PROMs.
Hi. Hi, everyone. Y'all can hear me well? Yes. Yes, very good afternoon to all of you. And it's been wonderful hearing about all the sharing about the value-based care and about PROMs. And there's so much that we have been doing that I'm really very, I would say, excited about what's coming. First of all, let me just quickly introduce myself. I think today we are really talking about how we can improve healthcare, and my perspective here is about transforming healthcare through patient involvement. So I am at this discussion here today wearing a couple of hats. The first is I'm from the Office of Patient Engagement at the Lee Kong Chian School of Medicine, and I often like to say that what I do is to open doors to patient and public involvement, bringing patient voices into medical research and education. And that is because, and as we have heard from Nidhi as well as Brenda earlier, patients, they do bring unique expertise, which can actually help us to address many of the healthcare challenges we face today, as well as helping them to get better and have better outcome. And so this is what we do with all our patient partners at Open to integrate patient and public voices into healthcare solutions, research, and medical education. And when we talk about patient involvement, what we are talking about here and the work that I do, it's about whether it's research or innovations or programs that we're doing is being carried out with or by patients and members of the public rather than to, about, or for them. And that is really the crux of what I'm talking about today, because I think we have done a lot of good work has been done, and how can we do more together with or by patients and members of the public? So this, again, quickly, just to share some of the things that we do at Open is about changing mindsets, putting in the infrastructure, enabling patient involvement, creating the culture, and capability building. But that is my first hat. My second hat is I am also a breast cancer survivor and patient advocate, and this is how I came into this work. And that is why I'm bringing both perspectives into this discussion today. So we have heard so much earlier, from everyone about PROMs and value-based care, but I would say I want to actually, the thing that got me thinking when Nicholas invited me for this discussion is that should we look at what is the meaning of value? What is the value in value-based care? And I am actually very encouraged today to hear very much that value is not just about cost effectiveness or quality, though it seems like that is a lot of what value-based care tends to measure. But from all the speakers that we have heard earlier, we're really talking also about what is meaningful and the outcomes that are meaningful to patients and the families. And Brenda, I particularly like the phrase that you have used, meaningful outcomes and not just clinical outcomes. So I think that's something that we really need to think about, use more often. But while we say all that, I feel that, we say patient-centered care is important, but I find that what is often missing in most of the conversations that is about value-based care or about PROMs is that it tends to include everyone except the patients and families. And that in itself is my question to everyone in this webinar today, is how can we embed patient perspectives into this entire system better? How can we do more of what Brenda has just shared with us, where that is also included in how the care system is developed? And therefore, I have three perhaps suggestions for everyone to consider on what can we do to include what matters to patients in healthcare. Can we look at embedding patient-centered metrics better, PROMs and PREMs into the entire value-based care system? Are they part of the system at the moment, or are they at the periphery? Actually, this morning, I'm really excited to see that somehow the stars aligned, and our local newspaper, Straits Times, had an article about how Singapore and the ministry actually is looking at, including more PROMs into the healthcare system. So I think it looks like, we are on the right track. But I think we can still do more in this space. And perhaps this is something for the panel and everyone in this webinar to look into. Second, I think there is also a call, and NIDI has also made a call for more inclusion of patient and caregivers partner to be part of these value-based care programs. And I would also want to make a call for PROMs development and adoption. And when we say inclusion, it's not just about including, say, hey, let me invite 2 patient partners to be part of one discussion, but can we look at more systematic inclusion so that they are part of this entire system in how we do things? And, earlier, there was mentioned that, we wanted to look at more adoption. Albert had mentioned about more contextualizing of PROMs into the local setting. Besides working with clinicians, can patient partners be included in this adoption adaptation? So these are some of the things that I hope we can also consider. Last but not least, is change of mindset, new processes, and investing in resources. Well, I say this because I really recognize that all that we said on what we want to do above is not simple, it's not straightforward, because it really requires a change of how we do things currently, change of mindset. And that means, we have to make the changes, reviewing our existing processes in value-based care and in PROMs, perhaps putting in new processes as well and how we do it. And more important, and also as importantly, I have to be honest about this, it's about putting in resources to do this well. So overall, this is what are the 3 things that I feel that I would like to open up for more discussion by everybody on what we can do to bring patient perspective into PROMs and value-based care. And perhaps as a way of a reference, in terms of patient and public involvement in healthcare, this is not new. I think it's been done in some levels all over the world. And it has also been done, in research, and this is something that we're starting to look at here in Singapore, though of course it's more well established in some other countries. And there is actually a format, a way of doing things. And I'd like just to share this infographic with you. It's from the university, Oxford University, on how patients can be involved in the entire research pathway. So similarly, let's say we talk about PROMs, how can patients be involved in the PROMs development and adoption? I'm sure we can do that too. And in fact, I just read over the weekend a paper about that, on how patients can be involved in the entire PROMs development, from development of a conceptual model to item development, psychometric survey design to the design of the PROM, for example. So these are some of the things that I would like to encourage all of us to look at more if we want to make value-based care and PROMs to have meaningful outcomes, that we are looking at meaningful outcomes. Thank you.
Thank you very much indeed. And again, for sharing your insights and picking up on something we've also been finding in some of our research, looking at the policy brief around some of maybe the deficiencies that there are currently, although they're being addressed, I think, in terms of patient involvement in this and other things. So really strong message coming from you. Thank you. We want to come to our last speaker now, since we've got about 15 minutes left. So we're only 5 minutes behind time, which is pretty good given the depth of all the information we've shared. I'd like to come to Shikha Kumari. Shikha, welcome. You're Director of Value-Driven Outcomes Office at the National University Health System, Singapore. Plenty of food for thought in these presentations. How are you, and it's part of your role to start to embed these new ways of working. So your insights would be most welcome.
Thanks, Nick, and thank you, everyone. I'm not sure whether it was planned to put me at the last, and I didn't prepare any slides, so I think I'm feeling that, okay, I have taken notes of everyone who went ahead of me, and I feel responsible of for acting on every question which was raised and suggestion which was made. Wonderful suggestion, Nidhi and Eileen, I have noted. So while I was listening, I made few points. First of all, we at Singapore, and I'm coming from a provider's perspective. We have taken and implemented value-based healthcare in a real sense, or in a sense which it was meant or formulated by Michael Porter and Elizabeth Teesberg, which is to provide quality and affordable healthcare in our context to all Singaporeans. So that was where we have started and worked on in last couple of years. So what it meant was that we have fixed all the hygiene things. So currently I'm so proud and I'm so delighted to hear that we are talking about taking it to the next level, where we are thinking of how about adding what matters the most to the patient. But we cannot nullify and we can't ignore the things which are hygiene factor, as in the quality of care from clinical point of thing. So I'm proud to share that those are the things we have been taking care, and those are the hygiene factors we want. So what are we doing next and why? So Eileen and Nidhi, we had and Albert, we all know that we went to a stress time, and we have talked about the importance and some of our projects, which is implementing patient-reported outcome. So a couple of things, how we are seeing and how we are implementing in our healthcare system. So one is that we have acknowledged that patient-reported measures could be the common language to help ensure right citing. So in the in the last 1 or 2 years, all the health clusters have given the mandate to be the regional health manager. So National University Health System, we are the regional manager of the western part of Singapore. So what does that mean is that we don't really need to only look at the providing care in that particular setting, but we also need to work on the right siting to make care affordable, as well as give the best quality at the right site. And we are looking at or implementing PRMs, patient-reported measures, whether it's PROMs and PREMs and many other forms of experience and measures, to be the matrix to make sure that the quality is provided in the right set. Is if we are triaging patients in primary care or acute care or tertiary care, whether my patients are getting the best value in terms of clinical as well as the experience and measure. So that's something we are doing it. Another thing, one of the comment which Nidhi made is that, some of the patient advocates mentioned that the clinician don't know what is patient-reported outcome. And we have noted that, and reason being that there are a couple of things which we are setting and fixing and implementing and advocating within NUHS, is that we want PRMs to be provided to clinician at the point of care. And for this area or this point, it's not only the clinician who are responsible. The response rate and what patients understands of those instruments and provide the feedback, whether it's patient or next of kin or caretaker or whoever, is very important. I'm totally with you when you say that it requires whole education and building the culture. And that's where we are. We are going out, we are doing symposiums, we are doing a roadshow and everything across NUHS and educating public that how important it is for you to answer those questions in the way it was, in the true sense. So that's something, one of the things we are working on. And what we are trying to do is to work on the seamless integrated way of collecting PROMs. Again, putting that into care across the settings, Nidhi, in your pathway. So not only for NUP in NUH's perspective, or NUH and Ping Fong AH, or SLH or JCH, but this PROMs could be electronically being available to clinicians at the point of care for he or her to be able to make shared decision together with the patient at the time when patient is sitting in front of him or her. Having said that, it is important for those inputs to be provided by the patient in a right context. So that's something we are working on aggressively. Another or last point, and then I'm happy to take any question from anyone, is that barriers. So we talk about barriers and what are some of the things we are grappling at provider or cluster or even Albert Side Ministry level is that these barriers are beyond digital literacy. That do you know is like elderly, do you know how to use it or launch your WhatsApp or RedCap or let's say Form SG to answer, or is it in all the 4 languages in Singapore context? It's more than that. It's about culture. How much can you share? How how comfortable are you to share the questions, and more than that, the educational factor, that are you able to understand? So recently I'm implementing a Kansas myopathy cardiac prompts in our heart failure, and those 12 questions sometimes doesn't seems to be very easily understood by my 80 years old patient. And we all agree that this whole process is very resource intensive. So I need to have someone to explain that very patiently to my patient to get the right answer. As we always know that garbage in, garbage out, if we don't have a right answer, then analysis will be wrong, the shared co-design, everything goes fall. So we are working on it. We have started, we have noted, we are aware of most of the points. It's just that it's a big shift, cultural shift and paradigm shift for that. But we are ready to go on the next leap and include this in our strategy very intentionally. Thank you.
Thank you very much. There was one question that came for you, which is, do you have target response rates for some of your things that you put out? Or are you seeking
yes.
to, yeah.
Yes, so there are few response rate I want to quote. The conditions where we are manually collecting, not manually, it is electronically, but I have a coordinator to call after 2 reminders if the patient doesn't submit the response. Then my response rate can go as high as 70%. But those conditions, generic ones where I have not put that much resource due to many other reasons, then response rate could be as low as 15% or 10%. So from 10% to 70% is the range. Response rate.
It'll be interesting, yeah. So I guess there's a question for the whole group, but it comes up in a number of the questions that have been posted online. And the issue is around the issue of sense making of PROMs between clinicians and patients. And it's not just a design question of how do we develop PROMs in a way that's meaningful and understandable for people to develop. But what I'm seeing in the comments are people probably from the clinician or management side saying patients need to be supported to answer the questions in the right way, the way they were intended. I think you said a similar phrase. And similarly also that clinicians need to understand why it's important for them to get engaged to deploy PROMs and actually use that information proactively in clinical practice, which potentially they don't. So it seems to me that there are 2 things here. One is the cultural shift, going back to Dr. Ty's presentation at the beginning, to get people to understand this is important. But secondly, there's something relational here about how we can use PROMs or use value or use something where we can create some sort of, goes back to that relational reciprocity thing I think Brenda was talking about, to try to bring people together to make sense of these things, to get the best out of them. And I don't know whether there's a question in there, it's just a comment, but if anybody wanted to step in and say, well, how do we ensure that we both get the best out of clinicians in deploying it, the best out of patients in using it, and how do we create an approach that enables the 2 sides to work collaboratively to develop that. Professor Valderas first, and then others, please come in with your thoughts.
Thanks. Thanks so much for the question, which is in line with a number of things that we have seen in the questions and answers. I think there's at the heart is an issue of trust. We're asking people about information that is close to them and that they may not be necessarily certain what use will be done. So if I tell you something about my mental health status, what will you think? Who will be also listening to this, if I tell my doctor that I'm not getting better, will I get, and I know that that's used for the performance assessment, will I get a worse treatment as a result? Will the clinicians who may rightfully think, okay, I can give someone a prescription or advise them to do something, but they are able and choose not to, then why should I be hold accountable for the impact it has on PROMs? So I think it's very important to establish this trust, this openness about the limitations, about the implications, and allowing all these things to emerge because these are very significant barriers. And once they are overcome, I think that patients clearly recognize that the perspectives being articulated and used for making decisions, it's something that most of the time they seem to be happy with. And the clinicians also, they have now something that is more technical than just asking the patient how you are. So these are metrics, these are numbers, these are things that perhaps more aligned with what people understand these days for personalized medicine. So, but the limiting step is this trust.
Trust. Thank you. Well, trust came up a lot in the presentations, actually. Nidhi, I think you had your hand up, and then I might come back to Brenda as well, because I think it was central to her presentation. Nidhi, did you want to make a comment?
Yes. Sorry again. Sorry. I wanted to bring up 2 points. One is the priorities of a patient might not be able to be addressed by a clinician. I give a very specific example. Fatigue is a big issue for people living with Crohn's disease and ulcerative colitis, but there is no medication to help. So it might be brushed aside, but there are huge studies done globally which highlight this fact. So what I would then suggest is such issues should be brought into the attention of, let's say, the research community, the pharma community. That is one point. The other point is when we look at ICHOM standards that have been set for different illnesses, and there are only a few so far. I think Albert highlighted the stroke one. Fortunately, we have one for IBD, people living with Crohn's and colitis. But there is a shortfall there, which I have highlighted to the co-founder of ICHOM. And I think they're going to rework it. And it aligns with Brenda's point that mental health is part of a chronic illness management. So these are things we need to look at carefully, look at it in the context of Singapore, include patients and the entire ecosystem. PROMs is very powerful. I look at it as a binding force. It can bring us all together. So that's it. Thank you.
Thank you so much. I might come to Brenda for some comments about trust, and then I might come back to Dr. Albert Tai for some final remarks, and then I think we'll need to wrap up. Brenda. Oh, you're muted.
Say that again.
You're muted, Brenda.
Hello.
Oh, you're good. Yeah. Hi.
Thank you for highlighting trust. I think the whole mechanism of behavioral relational reciprocity is to produce trust. And trust is essential for trading partners and exchanges, whether it's economic or relational. And I think that's why we were so able to build mental health integration and routinize it in primary care, because it was a home base of already existing trust. These physicians had these patients and families. They knew their families. They knew their grandchildren. There was a longevity to how much they've been helping and supporting each other. And so I think being able to align measures of trust is also going to be important, because if you don't have the trust, you can't get trustful, meaningful reported measures, because people aren't going to tell you how they really feel, or physicians may not want to comply because they don't trust that their job isn't on the line. So having trust be an essential outcome that you're trying to develop with your culture, I think is very, very critical. And I think you've all mentioned it. And also the patient report, the patient experience, the patient's journey, what happens to trust at each of those levels of going to all the different providers and not really having the time or the mechanism or the culture around it to develop trust with that person. And so you need a home base. You need a home base of trust by which you can launch off with new information and also be able to build that. So, yeah.
Thank you. So come back to Dr. Tai. You mentioned a far-reaching policy vision and the need for significant cultural change to achieve it. Do you have any final thoughts on the dialogue?
I echo everybody's sentiment about trust. Definitely trust. I mean, that's the foundation of a doctor-clinician patient relationship in the first place.
Right.
But I think the part of the trust actually also is that, clinicians have been trained to like trust blood tests, investigations, X-ray results, and that's how they form their decisions. And I think with the entry of PROMs here, actually, we shouldn't see them, at least from the view of AVBC, we see PROMs not just as supplementary data. It's not just there for the sake of collecting it. It should form part of the decision grid. It should be form part of the decision-making process. So if we are serious that, if we take blood tests as seriously as, as an outcome of what management is what kind of outcomes patients are experiencing, I think PROMs play a very significant role because it does tell us whether or not patients are truly benefiting from whatever treatment we're giving them. So I think I've heard a lot of good thoughts. And in fact, actually, my team is here as well, and I've been telling them that if you ask around the clinicians, sometimes even our own policy bosses, actually, they will always ask us that do PROMs really matter? Do they change management? And I think we have found. I told them that please, screenshot all the evidence that we have so we can throw this back to them and say yes, it does, and because it is as important as clinical outcomes when we look at what matters to patients. So I think that's thanks again for allowing us to share the ministry's vision and also all these people here now who actually are partners in making it happen.
Thank you so much. My apologies to Aileen and Shika, but we're past our time. So we're going to need to wrap up. It's been a fantastic session. You've all been able to provide such amazing insights. As I say, we'll be getting in touch with everybody who's been online today with links to the webinar and also to the slides. We didn't get to all of your questions, so we will commit to looking into those questions and providing responses to them. If you enjoyed this, please join us next week on the 12th of February for our next policy dialogue on social prescribing at the same time. So you can look online to find that. But with that, I'd like to thank all of our speakers here today and for you for joining us. And we look forward to seeing you next time.
Thank you very much. It's an honor to present with all of you.
Thank you very much.
Thank you.
Thank you.
Thank you all.
Thank
Bye-bye.
you. Bye-bye.